As you can see, we are recording today's session. And for those of you who are not familiar, the iPro Quality Innovation Network, Quality Improvement Organization, covers 11 states plus DC. And together with health centric advisors and Clarent, covers about 20% of the nation's Medicare fee-for-service beneficiaries. And one of our focus areas is immunizations, which is why we're gathered today to kind of get vaccine season started off. Next slide, please. I'm sure you're all familiar with Zoom by now, but just in case, you can find the chat button at the bottom, the black bar with the icons. And we do encourage folks to chat in today. Let us know who you are, where you're coming from, what the weather is. And also, if you have any questions, we do definitely want to hear from you, and we'll be getting to questions towards the end after we go through the content. Next slide, please. So as you saw, we're recording today's session, and again, just let us know if you have those questions, but keep yourself on mute during the presentation just to help with background noise. We do appreciate that. And without further ado, I do want to start introducing our speakers for today. So Mary Ellen Casey, she's a Senior Quality Improvement Manager and Infection Preventionist for Health Centric Advisors. And she has over 30 years of nursing experience in multiple different care settings with a focus on infectious disease. For the last 14 years, her primary area of focus has been prevention and control of infectious disease. And she has also worked to prevent the spread of healthcare-associated infections. Tanya Fadala is a senior pharmacist at iPro with 19 years of clinical pharmacy, community pharmacy, academia, quality improvement, and medication safety experience. Prior to joining iPro, she worked at various community pharmacies and taught at Albany College of Pharmacy and Health Sciences in Albany, New York. She specializes in medication therapy management, medication reconciliation, opioids, immunizations, and patient self-care. Melanie Ronda is the Assistant Director and Nursing Home Lead for New York, New Jersey, and Ohio, and the Infection Preventionist for the iPro QIN-QIO. Melanie has been in healthcare for 25 years and has a wide variety of experience, including acute care, primary care, and long-term care. Prior to joining iPro, Melanie worked in a long-term care setting as Director of Nursing. So it's great to have you all here today to give us your expertise. And with that, I'm going to turn it over to Mary Ellen to get us started. It's all yours.
Thanks, Laura. Next slide, please. It's great to have you all with us this afternoon. Our learning objectives for this session are to recognize the disease burden of influenza, pneumonia, and COVID-19. We'll talk a bit about that. And identify some vaccine recommendations for the adult population specifically, and review strategies to help increase vaccination rates. Next slide. So to frame this conversation about vaccine strategies, it's really important to understand the disease burden that goes along with influenza, pneumonia, and COVID-19. Next slide. So we'll start with influenza, and probably no surprise to folks on the call. A lot of the information on influenza has not really changed. On average, 8% of the US population gets sick from the flu each season, although that can range from 3 to 11%. We know complications besides getting influenza include bacterial pneumonia, ear, sinus infections, and worsening of chronic medical conditions. Certainly things like CHF, asthma, and diabetes that we're concerned about from an immunocompromised state. Also, a lot of times these folks are in the hospital frequently, and that lends itself, to some concerns of increased risk. Our high-risk populations have not changed. 65 and older continue to be the highest risk. Of course, people of any age with certain chronic medical conditions compromising their immune system. Pregnant women, in the sense that their immune system is actually pretty hypersensitive. So it certainly is always a challenge for pregnant women in the flu season as to how their immune system reacts to that. So it certainly impacts the mom as well as the baby, and then children younger than 5. Next slide. So the disease burden for influenza really it varies widely season to season, and it's determined by a few factors. Certainly the characteristics of circulating viruses. We know that the flu virus can change, mutate. It seems to get better and better at mutating every year, in some cases mutating in the middle of the seasons. We've seen that. The timing of the season, is it early flu? Is it late flu? How well the vaccine is actually working to protect us, and certainly how many people are getting vaccinated for the flu season. We know that deaths can range anywhere from 12,000 to 52,000 annually. Hospitalizations up well over 700,000 at times, and illnesses anywhere from 9 to 41 million. So it's certainly, while our focus has shifted the last couple of years with COVID, influenza is certainly a very concerning disease with high morbidity and mortality. Next slide. So I was sent this by a colleague. It was a little bit concerning. Australia is having a bad flu season. If folks haven't seen this, this was actually reported last week, I believe, by NBC News, that Australia is actually having quite a bad flu season. And interestingly, the timing is well, good or bad, I guess, based on your perspective. But the US tends to get a heads up for upcoming influenza seasons, which is good. We see the trends in the Southern Hemisphere, so it sort of gives us an idea of what to expect. And the flu is surging in Australia currently. This is the first time since the pandemic began that this has happened for them. And this is actually the worst flu season they've seen in 5 years. So we know this isn't an exact science, but it certainly is a tool that CDC uses to sort of prepare folks for what lies ahead. And certainly with little flu in the past 2 seasons, our immunity has waned. So certainly a concern going into this flu season. Next slide. Switching gears to pneumonia, pneumococcal disease, certainly another disease of concern, where there's an estimated 150,000 hospitalizations each year in the United States. And this is data from 2019. It certainly is a concern for invasive disease as well, with pneumococcal meningitis and bacteremia causing over 3,000 deaths in the US in 2019. And I think a lot of people, think of pneumonia as strictly a respiratory lung disease, but the complications from that are really meaningful and certainly of concern in terms of vaccine production and what's going to be the most effective against pneumococcal. The burden is high, no surprise, especially again for those over 65 and those with chronic and immunocompromising conditions. And again, we think of pneumonia, but bloodstream infections and meningitis are also putting people at increased risk of morbidity and mortality. So next slide. Streptococcus pneumoniae is the organism that I'd like to concentrate on, because this is certainly one of the more serious strains causing pneumonia. This is a gram-positive anaerobic bacteria. The interesting thing about it is there's more than 100 known serotypes of this organism, but there's only a few of the serotypes that actually produce the majority of the pneumococcal infections, particularly that severe invasive pneumococcal infection. The other thing that's interesting about this organism is the carriage of it, or the colonization. So folks, normal healthy individuals are carrying this organism around with them, sort of living in harmony with them, if you will. Similar to MRSA, we talk an awful lot about that it's a common skin organism. So a lot of people just live with it and are none the wiser that they're carrying it around. So studies have shown that it may be isolated from the nasopharynx of 5 to 90% of healthy persons. So if you break that down a little bit, and I found some of these percentages really surprising, 5 to 10% of adults without children are carriers. School-age children is not a surprise. The percentage is a little bit, 20 to 60% of school-age children may be carriers. And more interesting to me was 50 to 60% of service personnel on military installations may be carriers. So there's a lot of research still going on about this, and researchers still aren't clear what is the link between being a carrier of Streptococcus pneumoniae and your natural immunity to it. So if you're carrying this around, are you more prone to be immune to it? Are you more or less likely to pass it on to other folks? So it's just really important to understand that while we're targeting the elderly and the folks most at risk, that there are the folks around us that may be harboring this organism and not even being aware of it. Next slide, please. So the risk factors for invasive pneumococcal disease, age again under 2 and greater than 65 years. Certain racial and ethnic groups are at a higher risk: African descent, Alaska Natives, and American Indians. Male, your gender is male, you're more at risk for acquiring this. Chronic diseases, again, no surprise, depending on your immunocompromised state. Substance use disorders are also a risk factor, particularly alcoholism. And the other interesting factors with cochlear implants, folks that have had these implants are more at risk for the invasive meningitis form. Next slide. Turning to COVID-19, which when you talk about disease burden for COVID-19, I feel like we're still flying the plane we're building, as we said it early in the pandemic, just trying to learn the guidelines quickly. But the disease burden is really, we're living it. The history is being written at this point where the disease burden is going to be with COVID-19. But we do know this, that there's almost 90 million confirmed cases in the US to date. There's been over 1 million deaths. It was the third leading cause of death in 2021. It was actually the third leading cause of death in 2020 as well. We know that older adults and people with certain underlying medical conditions are more likely to get severely ill. But we also know that COVID plays a little bit of Russian roulette, if you will, with people who have been perfectly healthy prior to acquiring COVID and have become seriously ill. In fact, a lot of folks, we're learning more and more about post-COVID conditions where folks are experiencing a wide range of health problems that they actually, the onset is 4 or more weeks after they got the initial COVID infection. So the rebound COVID and all those things kind of fall under that we're really learning about disease burden as we go along. Long COVID is a phenomena too that I think you'll hear more about in the coming years, but these are folks that are experiencing long-term effects from original infection. And I'm sure all of us have stories to tell of young folks really that had no pre-existing conditions, were perfectly healthy. They get COVID and lo and behold, they get diagnosed with a cardiovascular disease. I know a young man who was diagnosed with AFib post-COVID and had no prior history or any inkling that was an issue. So certainly we will learn more as time goes on. Next slide. This is just a snapshot of the CDC COVID data tracker. I think at one point they were probably updating this minute to minute, but they do update this quite frequently, and it's a great resource for folks just to kind of get a snapshot of daily average cases, the deaths, hospitalizations, as well as what they're tracking on their home screen is vaccination rates for first booster doses. So while you look at this number here, the total first booster dose, and the number looks impressive until you look up top at the vaccination rate and say, we got a lot of work to do. Next slide. This slide is from the CDC webpage, their disease burden webpage, which is interesting to look at, and certainly I'll be looking forward to see how this plays out over what we've seen over the last year. This is data that they updated back in November of 2021, but it looked at the percentage of COVID-19 infections broken down by symptomatic illness, hospitalizations, deaths, and age groups. So, we talk a lot about herd immunity, and sometimes people poo-poo that. But if you look at this 18 to 49-year-old age group, they're the folks that were getting the most infections, had the symptomatic illnesses that we're aware of, obviously. But the folks that kind of paid the price for this were the 65 and older with their hospitalizations and certainly deaths. So while you may have seen fewer infections and symptomatic illness with this group for various reasons, the older group certainly felt the impact of increased mortality for sure. Next slide, please. Johns Hopkins has a great website. They have been tracking pandemic numbers since the very beginning, and it's just another tool for people to get some quick updates on. They do look at cases and deaths, but they're also concentrating now on vaccine tracking. So on any given day, you can go to their website and just kind of get a snapshot of where people are in terms of being fully vaccinated. I think it goes into a little bit more detail as far as what they define as up to date, but that's another good resource for just getting some general information. Next slide. So the other thing I wanted to talk about with disease burden with COVID-19 is the fact that this is very different from influenza and pneumonia. The mental health impact from the COVID-19 pandemic, it really cannot be overstated at all. There's a link here to the World Health Organization collaborated with their Global Health Collaborative to put out a scientific brief on early evidence of the pandemic's impact on mental health. And you can see the key findings here. It's estimated that the pandemic has led to almost 28% increase in major depressive disorders, 25% increase in anxiety disorders. They looked at where some of these increases have occurred in places, which is no surprise, highly affected by COVID-19. More in females than males, which makes a lot of sense when you look at some of the challenges that females have had with balancing the workplace and childcare and all those things. There's just so many factors that go into that. And of course, low and middle income countries, their impact impacts us all. And one of the things that it talks about in this brief is what we all know is that mental health services prior to COVID were not that great. And the disparities certainly that have occurred that COVID has shed a light on is mentioned as well. And although they didn't see a lot of suicidal behaviors early in the pandemic, they're seeing that is starting to increase now with younger people, particularly aligned with the economic challenges that people are having. So I wouldn't be surprised if they put out an updated version at some point, but this was a really impactful study. And as I said, it's long, if you want to read it, it's got some really great information in it. Next slide. Mental Health America, just again, another snapshot of where we are in the US. This is a nonprofit organization that really is working to raise awareness for mental health issues by early identification, screening, trying to educate and provide resources. And they do an annual report that talks about how many people are actually using their website and their app to take a mental health screening assessment. And as you can see, I just put a small snapshot of the graph itself, but the key findings showed, and this was published in April of this year, that in 2021, over 5 million people took a mental health screen. This represented a nearly 500% increase for them over the number of people who had completed a screening in 2019, and 103% increase over 2020. So, 2021 is high, 2020 high as well. So this is certainly an area of focus. A lot, I can remember I was working in the hospital at the beginning of the pandemic, talking to our social workers and their concern about, it's not only healthcare workers and the issues that they face with burnout and fatigue and all the mental health issues associated with that, but just the population in general, that this was going to be a second pandemic in terms of mental health post-COVID. Next slide, please. So we're switching gears to talk about some vaccination updates. I'm going to talk a little bit about influenza and COVID and then turn it over to Tanya for the more complex pneumonia vaccine updates. Next slide, please. So ACIP, the Advisory Committee on Immunization Practices, which is the advisory committee for the CDC, meets annually every year to make recommendations for the annual flu season. You've probably seen them a lot more in the news these days because they've met regularly for COVID vaccine recommendations. but they had their annual meeting regarding flu in June of this year. Next slide. And it was interesting because they found two things. Flu vaccines actually work better this past season than initially reported. They reduced the risk of flu illness by about 1/3 among the vaccinated. And I know a lot of people, especially people that I've counseled, will, put that number right back at me and say, that's terrible. But, I buy a lottery ticket, even though my chance of winning is a zillion million in one. So I think that's it's pretty good to reduce the risk. I always say that, whether they believe me or not, I'm not sure. And they also, this is the first year that ACIP actually had a preferential recommendation for the use of specific flu vaccines for adults over 65. CDC has never had a preferential recommendation. In fact, they don't do a preferential recommendation for people under 65, but it's a new day. So the ACIP has recommended that the high dose flu vaccines be administered, and it is pending CDC approval, which I'm sure is going to be momentarily. All signs point to the fact that they will be approving that recommendation. So basically, ACIP feels that the use of the high dose vaccines are really more effective for adults 65 and older, that they will avert serious outcomes from the flu. Next slide, please. So just to cover quickly what these vaccines are, and some of them are familiar to folks. Fluzone, I know I have used, although it's been a choice as far as the population that we vaccinated. Now it's more of a preferential recommendation, as I said. But the Fluzone high dose quadrivalent, that's approved for use in folks 65 and older, and this contains 4 times the antigen of the standard dose. So the idea is that it's a little bit got more oomph to it, and it's going to give a better immune response to vaccination. Next slide. The Fluad, again, approved for use in people 65 and older. This contains the same amount of antigen, but it also adds the MF59 adjuvant, which is designed to give a better immune response. So you're getting that flu vaccine, but it's working better for you. Next slide, please. Flublok, this is a recombinant protein vaccine. I think with all the vaccines on the market now, COVID, we've learned a lot about mRNA technology and all the things that you can do to manipulate these vaccines. But this was made using different production technology than the inactivated vaccine. So it contains 3 times the antigen of the standard dose. And this one is actually approved for use in people 18 years and older. Next slide. So the bottom line, we know the benefit outweighs the risk. It's really trying to have a conversation with folks to talk about these benefits. I don't have to read these to you. Most folks know that, these are definitely great reasons to be vaccinated against the flu. I would just highlight this idea of the risk of flu-associated hospitalization. I try and get away from any conversation about the flu shot is going to prevent you from getting the flu, because we know that that's not true. It will reduce the severity, but really, to me, it's a twofold benefit. It keeps you out of the hospital, and it keeps the hospitals open to be able to care for whatever's coming down the pike with COVID. I'm a little not concerned, but after last year, thinking we were coming into the fall last year, and whoo, that pandemic is finally starting to calm down, and then Omicron, we turned the corner and there was Omicron, and it was worse than ever. So I think that particular benefit is really a good one to reinforce with people. You don't want to be in the hospital if at all possible. Next slide. The approved COVID-19 vaccines we know about: Pfizer, Moderna, Johnson & Johnson's, Janssen. Novavax is a 4th vaccine that's new out on the market. It's not authorized for use as a booster, but it is another choice for folks looking to get immunized. And again, the vaccine data is posted very frequently on the CDC to see where folks are at. And we still, again, the numbers reflect that low rate for booster doses. Next slide. COVID-19 boosters, I'm probably preaching to the choir here that we know that they work to further enhance or restore protection that may have decreased over time. This is a dance, I feel, trying to recommend booster shots to folks who they're not sure, they think this is, they don't need it, or they're going to wait for the one that's coming down the pike. So it's a challenging conversation, but this is where we're at with booster recommendations right now, and certainly keep your eye on the CDC website for more changes as they occur. But 2 boosters are recommended for adults over 50 years and older, and some folks age 12 and older who have that moderately or severely immunocompromised state. Next slide. What does it mean to be up to date per NHSN? We have this conversation a lot because a lot of you may be involved in COVID-19 vaccination status reporting through the NHSN. So if the NHSN says it, we do it. And this is the up-to-date vaccination definition per NHSN as of the second. Probably will change right after this presentation. But what I like about it is, at least if you're getting a lot of questions about, well, what does it mean to be up to date? This is a sort of a good go-to to say, this is what it means to be up to date per the CDC's reporting division, if you will. But stay tuned, it's probably going to change. Next slide. This is sort of a mind blower visually to me when I looked at this. Is on the CDC website, and it's just a graph showing that we have work to do. It breaks down age groups looking at primary series completion versus your booster dose eligibility versus who's actually gotten booster doses. And while, again, you look at some of these numbers and say, wow, that's a lot of people. When you look at the rates, it's great, particularly in the 65 plus years, that they're at 92% for fully vaccinated. But as you scroll through and see that, we haven't even gotten to that point with the first booster, and the rates are lower with the second booster. So it's certainly, while we've gotten some great results with people getting vaccinated, we still have a long way to go. Next slide. There are great clinical resources on the CDC website, particularly for COVID-19. And I encourage people to bookmark this page because, again, we're living it as it's being written, right? So check in on this site often. It's got some great tools to help you in your practice. Their clinical resources on flu and pneumonia are great as well. It's just that this changes very frequently. Next slide. And lastly, this just came out. It was perfect timing last week while I was working on these slides that everybody heard on the news that CDC has changed their guidelines, and MMWR just put out their weekly report last week summarizing the guidance to minimize the impact of COVID. So it's a nice report, very comprehensive, talking about source control at this point, and also the vaccine's effectiveness. So you'll get an idea of how things are working. And it also talks about the different treatment options that people have now besides getting vaccinated. Next slide. And with that, I thank you for listening. I'm going to turn it over to Tanya to talk about the pneumococcal vaccine.
So hello, everyone. There have been some updates. So there is a little confusion on the pneumococcal vaccine. So I'm going to go through that with all of you today. Next slide, please. So I don't want to take the time to have you watch these videos right now, but definitely if you have a moment afterwards, go back through these slides, click these links, and watch these videos. Really important on why you want to vaccinate. Next slide, please. So as you all are very familiar, we do have some pneumococcal vaccines. We've had the PCV13 in the past. And as you know, we've had, excuse me, some others as well. But if you're looking, we have, and most people use the names for these. So I will use the names at this point. Prevnar, Vaxneuvance, Prevnar 20. So there's the 13 and the 20, and then Pneumovax. So we know that all of these are now available. 2 of them became available right at the end of last year. So that's really important to keep in mind. Next slide, please. Here is really just emphasizing the difference between them, what was added. So you can see between 13, which was kind of the standard, where they added 2 to make the 15. 7, obviously, to get to the 20. The PPSV23 is a little bit different, though, in the fact that it contains polysaccharide antigen from 23 types of pneumococcal bacteria. So it's made a little bit differently, but it is still one of the front runners, actually. And you'll see that in a minute when we talk about which vaccine people should be receiving. And that really does also depend on which vaccines they have already received. So next slide, please. So as I spoke about, there were changes to the pneumococcal vaccines at the end of last year. So the 2 new ones were the PCV15 and the PCV20. We talked about, what the additional pieces were. It's shown on the last slide. And this is just a little bit about what you need to do. They need to be refrigerated. The injection site is the deltoid muscle. So same idea as those from before, but just reinforcing that information. Next slide, please. So what's really changed? So as of October, when those new vaccines came out, they changed their recommendations, no surprise. So for those who've never received a pneumococcal vaccine or it's unknown, you want to administer PCV20 and they're considered complete. Their whole cycle is complete if they have received PCV20. But if they've received PCV15, you need to follow that with 1 dose of the PPSV23 1 year later. And this can be super confusing to remember which one comes first, which one happens, when are they done, etc. So they actually have made apps and a website to make this really easy. And we're going to go through a case in a minute and you'll be able to see how that website works. And it's actually really helpful. I would almost recommend you not memorizing exactly the order that these go in, because 1, they're probably going to change again at some point. 2, it's better not to think you're correct. It's better to be correct and look it up. So, using those resources available to you are going to be super helpful. So the last bullet, I want to make sure that I do cover it. For those who have received the PPSV23, but not a conjugate vaccine, you may administer the PCV15 or the PCV20 at least 1 year apart from them receiving that PPSV23. So as you can see, I had trouble saying it and I know it. You can imagine what it's like for anyone else. So again, do look it up. So next slide, please. One of the things that you really want to think about when giving the vaccines is the risk of your resident or your patient. So as she spoke of earlier, cochlear implants, that is a much higher risk. So, you want to make sure that if you're finding a way or who needs the vaccine soonest or, whatnot, these are the people that you want to get it to. Anyone with a cerebrospinal fluid leak, persons with functional or anatomic asplenia, including congenital or acquired asplenia, sickle cell disease, or other hemoglobinopathies. Okay. Also, anyone that's immunocompromised, and there's always a huge list of immunocompromising conditions. So just keep that in mind as well. Next slide, please. So we talked about this a couple slides ago and we did it really briefly, but I just wanted to make sure and to stress, as you can see what's in red here, we talked about those that need specific vaccines and when they need them. So for those who have never received a pneumococcal vaccine or history is unknown, you want to administer that 1 dose of PCV20 and their series is considered complete. Or PCV15 is administered and it must be followed with 1 dose of that PPSV23 as we discussed. The interval is 1 year and that is what's recommended. However, it can be 8 weeks in adults with immunocompromising conditions, cochlear implants, or cerebrospinal fluid leaks. So it's just something to definitely keep in mind. It's not always that 1 year. So again, the website and the app are really going to walk you through those pieces. And again, the last bullet, for those that have received the PPSV23 but have not received a conjugate vaccine you will want to consider giving them either the PCV15 or the PCV20 at least 1 year apart from when they received that original PPSV23. Next slide, please. So here's the websites, and I'm not going to have you stay on this one too long. So just next slide, please. What those links lead to, the first link leads to this, which is a PDF, which, you know, you can print out, post, do whatever you need to do. Obviously, you want to make sure that you are making sure it's still up to date and recommendations haven't changed. But this is something that you could print out, have that really kind of walks you through who should be getting the vaccine and when they should be getting the vaccine and which vaccine they should be getting. Next slide, please. Now, here's a quick case. We have 2 of them. I'm only going to go through one with you today. But as you can see here, the patient's 72 years old. They've received 1 dose of the PPSV23. They have not received the PCV13, and they don't have any real risk factors. So if you could actually click on that link for me, Ryan. Just takes a minute to flip between the screens. You can bear with us. There we go. Great. So you can see it brings you right here and it's asking you to select an age group. So we know the patient is 72. So we want 65 years and older. Has the patient ever received the PCV15 or the PCV20? It did not tell us anything about that. So we're going to say no. Has the patient ever received the PPSV23? And that's a yes. We know that they received that vaccine. And we're then asked if they've ever received the PCV13, which it specifically said they have not. So that is no. You'll click proceed. And this lays it right out for you. So it gives you the recommendation over on the left. You may give 1 dose of PCV15 or PCV20 at least 1 year after their last dose, I should say, of PPSV23. Regardless of which vaccine is used, whether that's the 15 or the 20, their pneumococcal vaccinations are complete at that point. And the patient characteristics, you can always double check that you entered it correctly, that they're over 65 years of age. They had received the PPSV23, no PCV13, and no risk factors. So this really walks you through very clearly for each specific patient or resident what you should do in regards to pneumococcal vaccinations. So I'm going to have him go back over to the slides for us. Thank you so much. You can actually skip ahead a couple because that's just essentially what we just saw. There is a second case. I'm not going to take the time to flip you back and forth, but you guys get the idea. It's very basic. You can just go straight through and you're able to get that. So thank you so much for going to the next slide. And I believe I'm turning it over to Melanie at this point.
Thank you, Tanya. I love the hearing about the updates with the pneumococcal vaccine and that the 20 can cover you one time, one and done. I love one and done, right? So you can go to the next slide. Mary Ellen and Tanya did a great job talking about the disease burden, why we need to be vaccinated and how to be vaccinated. So I'm going to talk a little bit about how you can develop your vaccine campaign. I like to think of planning the vaccines in a facility or a hospital or healthcare center of any sort as a campaign because there's so many components to a campaign. And to me, a campaign sounds positive. So if we're putting together all of these actions, you want your result hopefully will be good. So, in the development phase, the first thing you want to do is plan your action for your campaign. What is it? What's your goal? How do you want to do this? Who's going to be part of your campaign? Who within your organization should be talking about this with you? You need some leadership. You need communications, people that are going to get out there printing newsletters or letters, whoever those are within your organization. Start to think about who's going to be part of the campaign and what is your goal of this campaign. Do you want 100% vaccination compliance for your staff? Do you want 100% offer for every patient or resident that is in front of you? So, or 100% education that gets out there to your patients, residents, or families. So decide what your goals of your campaign are going to be. Strategies to ensure cost-effective practices. So that could be, how are you going to communicate? Are you sending out flyers? Are you going to email flyers? Are you going to use your own staff to do the vaccinations? Or are you going to hire people in to help with vaccinations? And what's the cost benefit to that? So really taking a look of how have you done it in the past and what way are you going to do it to be cost effective? Are you getting pre-filled syringes? Are you going to need to change needle heads for safety devices? So think about all those components. Processes to streamline the billing, depending on where you are. Are you doing a clinic? Do you have the paperwork available? Is it easy to get access to people's insurance cards if the immunization's available immunization? So think about those items. Don't leave that to the very end. How are you going to manage the billing? I know in certain clinics, when you're going to be offering vaccine to 300 people, you really need to make sure you're using cost-effective practices, and the paperwork needs to be streamlined, or it's going to be a real challenge to get through that. So techniques to integrate other QI priorities within an immunization plan. So consider that this might be your opportunity to do a PIP that you're going to put through your QAPI process, depending on what type of organization you are. If you are a long-term care facility, doing a PIP and putting it all the way through your QAPI process is going to be important to show how much effort and support you've put into your vaccination campaigns, especially with the highlight and surveys related to your COVID and influenza are going to be top priority this year. Next slide, please. So identify your immunization champions. And we have heard a lot of different scenarios of who people are choosing as their immunization champion. It could be your outspoken CNA that really has seen the benefits of having gotten the COVID vaccine. It could be them who's going to be your immunization champion, or it could be someone within the leadership team. But look at your organization as a whole and identify the people that staff listen to and also support immunizations. Vaccine source. So being prepared and knowing where your flu vaccine's coming from this year. Where are you getting your COVID vaccine? Where's the pneumococcal? Do you have access to all of the pneumococcal vaccines? Is now the time when you're sitting down, building your action plans? Is it time now to bring it to leadership that the PCV20 now is the time to make that change, so you don't have to have a variety of different vaccines in the building. So just be considering where you're getting your vaccine from. And standing order policies, that's important. So know your state responsibilities, know your nurse practice acts and your scope of practice, who can actually administer vaccines, do the standing orders work for your vaccine clinics? Each state is different. Immunize.org is a wonderful website to look for materials and tools to support your vaccination. So they're, and I believe it was put in chat, the use of standing orders for administering vaccines. So when you decide on that, you also want to make sure you're deciding on how are you going, if somebody has an anaphylactic reaction, do you have some standing orders for that? So take a look at all of the practices with your standing orders. So ensure screening for vaccination is included in assessment tools. So sit back and think about right now how many times somebody is one of your patients or your residents is being assessed or screened? Is talking about vaccines part of each one of those things? What if they're coming in for a pre-op physical? Are they being asked about vaccines? And if they are and they need a vaccine, what are you doing about that? Is there a process, a foolproof process, where somebody's actually offered the vaccine, maybe even after the procedure? But making sure that you're screening and assessing, but also what is the follow through on those tools and resources. Next slide, please. So educate. I can't say this enough, and I think any of you who've been out working during COVID and when the immunizations came out and the COVID-19 vaccine became available, we needed, and I was working in a facility at the time, we needed to be very educated with whatever we knew, because we were constantly out there myth busting. It was a constant state of, well, I heard this, but this is what I've learned. This is what these people are saying. So you're constantly bringing forward as much information as you could. So making sure you're aware, update yourself to the guidance, get familiar with ACIP that Mary Ellen was speaking about, know CDC, educate yourself on your local disease burden, because that can help your campaigns and your conversations with patients, residents, staff. If you're saying, well, listen, the flu is really going to be a problem this year. We just learned about Australia. This is the opportunity to bring it right now to your staff to say, hey, pay attention what's going on across the world. We need to be prepared and we need to be vaccinated so that we're safer and less severity of the illness. And build knowledge to break down the myths and the barriers. Instruct your clinicians to educate patients and residents at each interaction. So whenever there's contact with assessments and conversations with your patients and residents, when are they being asked about vaccine? And is that the only time? If somebody's newly admitted to your facility, is that the only time somebody's going to talk to them about vaccines until 3 months later from a quarterly assessment? Or is it talked about on discharge? Is the process that on discharge you send somebody to go to their primary care practice? Because that's a risk. Frankly, a lot of people don't make it to their primary care appointments. So if they can get it on hospital discharge, that's the best and safest way for your patients and residents. So making sure, if you do provide that vaccine, document your education and your vaccination. That's another real challenge that different facilities really struggle with. Documentation, they may have received the vaccine at CVS, but the person was not educated to make sure they're keeping that history of documentation on them at all times throughout the healthcare system. So making sure when you provide vaccine that you educate, provide a copy of the documentation, teach patients to bring that vaccination card with them, just like they're bringing their medication cards, because it's that important. Mary Ellen clearly told us about the disease burden, and making sure we're properly vaccinating our patients, residents, our elderly is so important in having that as a priority. And also, we also don't want to give them 4 flu shots because they've been to all these different places and no one remembers if they were vaccinated. So teaching people to bring that documentation with them. Ensure staff are aware of safe vaccine storage and handling. So if you are doing flu carts where you're going to the units or you're going out to home care setting, making sure people know how those vaccines are supposed to be safely managed during transportation and stored, that if something is supposed to be frozen, it remains frozen. If something has to be cold, it remains cold. If there's only a certain amount of time that it can be allowed in the syringe. If you're doing a mass clinic, a lot of times people pre-draw, making sure your staff is well aware of the limits doing those types of things. So I highlighted temperature during transport, but there's a lot of components to that. So being fully knowledgeable of how managing vaccines is very important. Next slide, please. So messaging, I think that's a huge part of what we're doing. If anybody can open up chat and say, is there a vaccine messaging or slogan, or what's your vaccine campaign title? Go ahead and put that in chat. I'm interested in knowing what you've used in the past, or a slogan that you thought was great. I thought our title to our program was pretty good. So get your slogan out there, get it out there, get people knowing your messaging. How are you preparing the facility staff clinic for vaccines as they're coming out? So what are you doing? Are you telling, hey, you're telling your staff right now, get ready, influenza's coming? Just like bringing forward that Australia is having a bad flu year. Maybe that would be helpful, but start preparing your staff that this is coming. Are you developing some letters to your families, your patients, your residents, the staff? If you're connected to a primary care, what kind of messaging do you send out to your patients in the primary care setting to let them know they need to be vaccinated with COVID, pneumococcal, influenza? Communication at the bedside. So the CDC recommends the SHARE method. Next slide. I thought this was a really nice way. This is a really nice way to look at it from a perspective. You can train your staff, whoever is talking to the resident or patient, share the reasons why vaccine is right for this patient, given their age or their history, their medical history, their lifestyle, their occupation, whatever, but share the information, highlight positive experiences with vaccine to reinforce the benefits. And that could be personal experience if your staff is comfortable with that. They could talk about reasons why they get vaccinated, or some just positive experiences. Address patients' questions and any concern about vaccines, including side effects, safety, vaccine effectiveness, in plain and understandable language. So important for us to make sure we're aware of how we're communicating, and making sure we're using health literacy. And if in fact we are providing flyers and pamphlets, that is in the language that the person you're trying to reach understands, and of the and readability for that person. So being aware of that is very important. Remind patients that vaccines protect them and their loved ones from serious illness. A lot of times people may not get vaccinated for themselves, but when you start talking about the people that they love and how it's important for them to protect their loved ones, it gives it a whole nother meaning. Explain the potential costs of getting sick, including serious health effects. We have long COVID, we have time off, continued respiratory issues with flu and pneumonia and pneumococcal. So there's a lot of reasons to be able to explain why getting sick would not be a good idea. But using this SHARE method right at the bedside, or at every time you're talking about vaccines, is a very easy way for your staff to educate people. Next slide, please. So that is just kind of talking about your campaign. So I just wanted to go over some summary of today's events and conversation. The disease burden associated with influenza and pneumonia is substantial and can be reduced by or prevented with vaccines. So that's why it's so important. COVID-19 continues to impact both physical and mental health, disrupts lives, and creates social and economic hardships. Efforts need to continue to encourage vaccination and improve health outcomes. Don't quit now. It's so important to continue these conversations and hope for the slow yes, and talk to people individually and use the SHARE method. Pneumococcal vaccine recommendations have changed. We learned that, and there's an app for that. So that link was put in chat. Go ahead and get comfortable with that app to make decisions on your patients and residents. And consider the way the facility approaches vaccines. Is there a process to develop tools, resources, properly educate all, and communicate? Make your vaccine campaign a slam dunk. Next slide, please. So we are very excited to tell you that we've been working on an influenza, pneumococcal, and COVID-19 immunization toolkit. And this is a little snapshot of the cover. It will be released very soon. And it has a lot of valuable information. It's a wonderful toolkit. And we will get it out to you soon. Next slide. And so I am going to turn this over to Laura, and you can start chatting in any questions.
Thank you so much, Melanie, Tanya, and Mary Ellen. That was excellent. Thank you for sharing your expertise with us. And we do have a couple of minutes for questions. If anybody wants to, put it in chat, let us know, what you're thinking, or, if you have a successful strategy like that great campaign slogan that you want to share, we'd love to hear from you. And just so you know, the slides and the recording will be available on our website. It'll take a little bit to get it up there, but we'll for sure have it available. So, and actually, I have a question while people are thinking. So, what is different about the Novavax vaccine compared to the other COVID-19 vaccines?
The Novavax is actually, it's the 4th vaccine authorized by the FDA for the prevention of COVID, but it's unique among the other vaccines because it uses a traditional virus blocking technology, one that's been used before against other diseases. So it has a very good efficacy at 90% against mild, moderate, and severe disease in their clinical trials. The advantage is, especially for people who feel that they don't want a COVID-19 vaccine because the technology, it's new, they're not so sure about it. This is another option with more traditional production of a vaccine. So that certainly is an advantage to that. But again, it's another choice for folks to have in terms of what vaccine they feel most suits their needs. It's not available yet as a booster, so that may sway people as far as their decision, because if you're looking to get booster vaccines against the Omicron, the variants and all that, you might want to stick with what we have so far or what's coming, but it is a choice for folks, particularly, like I said, for those that are anxious about the new research and the new production technology that's out there. This might allay their vaccine anxiety.
Great. Thank you, Mary Ellen. All right, next slide, please. Well, people are thinking about any questions. We can look at, we do have a list of resources here that are in the slides. And I also put in chat, you can go to our resource library. We have additional resources there related to immunizations and a variety of other topics. Next slide, please. And you can go to the last slide. So here's our website. I'll put that in chat as well. So, if you're looking to connect with us and explore further, we do encourage you to visit our site. You can, find our contact information through there as well. And we, thank you for joining us today. And, good luck with your vaccine campaigns, and I hope everybody stays well. All right. Well, have a good afternoon, all.